Sometimes you see a little red mark on a kid, right?
Mm-hmm.
And you might just think, oh, it's a rash, maybe a bug bite.
Yeah, happens all the time.
But, well, it turns out that sometimes these seemingly similar skin things in children can actually be quite different underneath. Some are these things called vascular tumors.
That's exactly right. And it's a really complex area. So to really get our heads around it, we've been digging into Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. It's pretty much the authority.
Right. So we're kind of using that as our guide for this deep dive into pediatric vascular tumors.
And the goal really is to help understand the key differences between the types, how they behave over time, their natural course.
And how doctors manage them nowadays.
Exactly. Because, it's important to say, most of these are benign, totally non-cancerous.
Okay, that's reassuring.
It is. But knowing the nuances, the subtle differences, well, that's crucial for getting the right care and honestly also just for easing parents' worries.
Absolutely.
Yeah.
Okay, so let's start breaking this down. One of the first big things, the really fundamental difference, is between vascular tumors and vascular malformations.
Right.
They might look similar on the skin, maybe raised, maybe flat, different colors, red, blue.
Yeah, the appearance can be deceptive.
But what's happening inside at the cell level is totally different.
It really is. The key is the endothelium, those cells lining the blood vessels. In vascular tumors, these endothelial cells are actually multiplying. They're dividing.
Ah, right.
We call it proliferative endothelium. Think of it like those cells are actively building more vessel tissue. It's growing because the cells themselves are reproducing.
Got it. So tumor equals dividing cells. What about the malformations then? How are they different?
So in vascular malformations, you've got abnormally formed vessels, maybe blood vessels, maybe lymphatic channels, but the cells lining them, they're not actively multiplying like that. They're quiescent is the word, stable.
Quiescent.
So yeah, a malformation might get bigger as the child grows, sure, but it's not, because the cells within the lesion are rapidly dividing. It's more like the existing weird vessels are just expanding or filling up.
So that basic difference in cell activity changes everything.
Completely. It dictates how they behave, how they progress, and ultimately how we treat them.
Right. Behavior is the key then.
Mm-hmm.
Now, Rutherford's highlights infantile hemangiomas, IH for short,
Mm-hmm.
and these are apparently the most common benign tumor in babies, something like 4 to 5%. That sounds like a lot.
It is pretty common, yeah. You see them quite often in infants, and, while most just pop up randomly.
Sporadically.
Yeah, sporadically. There are some interesting little hints about genetics. The text mentions a rare link to a chromosome 5 issue, and maybe more commonly, about a third of kids with an IH actually have a family history, usually a parent or sibling.
Huh. So maybe a slight inherited tendency in some cases. What about how they actually start? What makes them form?
So the pathogenesis, how they develop, it involves these progenitor cells, like starter cells destined to become blood vessels.
Okay.
But in IH, these cells seem to be a special type. They produce this protein, a glucose transporter called GLUT1.
GLUT1.
Yeah. And what's really fascinating is these IH cells, they actually share features with cells from the placenta.
The placenta?
Right.
Yeah.
But genetically, they're the child's own cells. So it's like this link back to the placenta, biologically speaking. It's quite unique.
That is wild. And the source also mentions hypoxia, lack of oxygen, as a trigger for growth.
Yeah, that's thought to be a major stimulus. The idea is maybe in areas with slightly lower oxygen, these specific progenitor cells get kicked into gear, start multiplying, and form the hemangioma.
Okay.
It's probably more complicated, immune cells, signaling molecules, all that stuff plays a role. But hypoxia seems to be a big factor, especially for that initial rapid growth.
Okay, so they appear, and then they have these distinct phases, right? Growth, then shrinking. Can you walk us through that timeline?
Sure. So first is the proliferative phase. That's the fast growth part. It's most rapid in the first, say, 8 weeks.
Wow, really early.
Yeah. And something like 80% of the total growth is usually done by about 5 months old. Then it typically slows down, maybe around 5-6 months. Although, for deeper ones under the skin, that growth phase might actually go on a bit longer, maybe even up to 18 months sometimes.
Ah, so a deeper one might not be as obvious right away and might grow for longer?
Exactly. The superficial ones near the surface, they look bright red,
Yeah.
but the deeper ones might look bluish or even just skin colored. And lots are mixed, bit of both. They often pop up around 3 to 6 weeks after birth.
Okay.
But interestingly, the book notes that in nearly half the cases, there might have been a little clue right at birth, like a pale spot or looked a bit bruised. Something subtle that then develops into the IH.
And then after the growth phase comes the shrinking phase, involution.
Right, involution. That usually kicks in around 1 year old. And during this phase, it gradually gets smaller, the red chire fades, maybe the middle bit gets paler, it feels softer.
And how long does that take?
For most kids, it's largely done by the time they're about 4 years old. And what's really interesting is what replaces it.
Oh, it doesn't just disappear.
Well, the tissue changes. It actually gets replaced by fat cells. And get this, those fat cells come from the same stem cells that made the hemangioma in the first place.
No way. So the cells just switch jobs?
Sort of, yeah. It's a transformation. So it's not like the vessels just vanish, the tissue remodels.
Okay. And after it's gone, are there usually any leftover signs?
Sometimes, yeah. If it was really big or deep, you might have some leftover sort of fatty tissue or maybe some loose skin. Scarring is more likely if it ulcerated, if it broke down.
Okay.
And you might see some tiny leftover blood vessels, telangiectasias, we call them, like fine red lines. Or maybe just a slight change in the skin color there.
Now, something else the source mentions. Multiple IHs. If a baby has several of these spots.
Right. That's a potential flag.
Why is that?
If a baby has more than 5 separate skin hemangiomas, there's about a 16% chance, give or take, that they might also have them inside the body, most commonly in the liver.
Hemangiomas in the liver. Okay, what does that mean? What are the issues?
Well, these liver ones, hepatic IH, can be multifocal, just a few scattered lesions. Often those don't cause any symptoms, found by accident maybe.
Okay.
Or they can be diffuse, where a larger part of the liver is involved.
And diffuse sounds more serious?
It can be. Multifocal ones can rarely cause heart issues, like high output heart failure because of all the extra blood flow. But diffuse ones, if they get really big, they can enlarge the liver, hepatomegaly.
Right.
That can cause breathing problems, belly discomfort, and rarely heart failure too.
That does sound concerning.
It can be. And there's another really interesting link with the diffuse liver ones. Almost all babies with significant diffuse IH develop hypothyroidism, low thyroid function, because the hemangioma tissue produces this enzyme, deiodinase, that breaks down thyroid hormone. So these babies need their thyroid levels watched really closely and often need thyroid hormone replacement.
Right.
But the good news is, as the liver hemangioma shrinks, involutes, that usually goes away. And it's crucial to tell these liver IHs apart from other liver problems like malformations or, malignant tumors, which look different on scans.
Okay, so multiple skin lesions means check the liver, potentially check thyroid. Got it. What about these syndromes, lumbar and PHACE? The acronyms sound complicated.
They definitely represent more complex situations. Lumbar is linked to large IHs on the lower body. Stands for, lower body IH plus urogenital issues, anorectal malformations, arterial problems, renal kidney anomalies, myelopathy, spinal cord issues, and bone abnormalities.
Whoa, that's a lot.
It is. These IHs tend to be big, often on the lower back, perineum, legs. They ulcerate more often too, and it's more common in girls. And importantly, if you see a big IH right in the midline of the lower back, big association with spinal cord problems like a tethered cord. So an MRI is usually a must in those cases.
Okay, definitely need specialists involved there. What about PHE?
PHE is another one, also more common in girls. This involves a large, often flat or plaque-like IH on the face. And the acronym stands for posterior fossa brain malformations, hemangiomas elsewhere, arterial anomalies, cardiac defects like coarctation of the aorta, eye abnormalities, and sometimes sternal clefting or a supraumbilical raphe that's like a seam below the belly button.
Again, a whole constellation of potential issues.
Exactly. And a big worry with PHACE is the higher risk of brain vessel problems, even stroke in some infants. So recognizing these patterns, lumbar and PHACE, is critical because these kids need a full workup, lots of specialists, and they might have higher risks.
So diagnosis isn't just looking. What tests do doctors use to figure out exactly what's going on?
Well, for most typical IHs, honestly, the history and just a good look by someone experienced is usually enough.
Okay.
But ultrasound is really useful. It shows a specific type of mass, high blood flow, certain pattern.
Right.
MRI is usually kept for trickier cases. If the ultrasound isn't clear, or if you suspect something deeper, or one of those syndromes like lumbar or PHACE.
And you mentioned that GLUT1 marker before.
Yes. Crucial diagnostic clue. If needed, a small skin biopsy can confirm it. IH cells stain positive for GLUT1.
And other things don't.
Generally, no. not other similar-looking vascular lesions like malformations or congenital hemangiomas. So that GLUT1 test is super helpful to be sure you've got the right diagnosis, avoid unnecessary worry or treatments.
Okay. So once diagnosed, how are these IHs managed? Parents must be worried seeing these things grow.
Absolutely. And for the vast majority, the main approach is watching and waiting,
Well,
observation.
let's watch it.
Yeah, because most are small, don't cause problems, don't affect function, or look too bad cosmetically, and we know they'll shrink on their own. So a lot of it is reassuring parents, showing them pictures of the typical course, explaining involution. But you do need to monitor closely, especially early on in that growth phase. Make sure it doesn't ulcerate, bleed, or start interfering with, say, vision or breathing.
And if it does cause problems, then you intervene early.
Yes, exactly. Early intervention, often in the first 1 to 3 months, might be needed for those complicated ones.
What kind of interventions are we talking about?
Well, for smaller superficial ones causing issues, topical beta blockers are common now, like timolol drops or gel applied right onto the lesion.
And that helps.
Yeah, it can help fade the color, shrink it a bit, but for the bigger or more problematic IHs, the ones interfering with function or growing really rapidly,
Right.
the first-line treatment now is systemic propranolol.
Propranolol, right. That's an oral medication,
Okay.
a beta blocker.
Exactly, taken by mouth. It works in a few ways. Constricts the blood vessels in the IH, reduces growth factors. Clinical trials showed it's really effective at making these things regress. It was a game changer.
I remember hearing about that.
Yeah.
Are there risks with using it in babies?
Yeah, there are things to watch for. It's generally safe when monitored properly, but you can see rebound growth if you stop it too suddenly, especially while it's still in that proliferative phase.
Okay, so you have to wean off it slowly.
Right, under supervision. And there are some contraindications, certain heart conditions, for example. Potential side effects can include low blood sugar, low blood pressure, maybe sleep disturbances.
It definitely needs careful management by a specialist.
Absolutely. Someone experienced with these conditions, historically we use corticosteroids, steroids,
Right.
but they have more side effects, both short and long term. So propranolol is preferred now. Steroids are more like a second-line option these days.
What about other things mentioned? Embolization, lasers.
Embolization blocking the blood supply, that's usually only for those really big liver hemangiomas causing heart failure that aren't responding to medicine.
Okay, specific cases.
Yeah. And laser, like pulse dye laser, that's often used later on. For the leftover tiny red vessels, the telangiectasias, after the main hemangioma has shrunk.
For cosmetic touch-ups.
Pretty much. Laser can also help if an area ulcerates. Sometimes a CO2 laser is used during the growth phase for tricky spots, like one blocking the airway, often along with medication.
And surgery? Do they ever just cut these out?
Rarely during the active growth phase anymore. Because propranolol works so well and operating when they're full of blood vessels, well, there's a big risk of bleeding.
Makes sense.
But maybe for a lesion that's on a stalk or one that's ulcerated, bleeding, causing real problems and where the scar might be okay, surgery could be an option. But ideally, if surgery is needed for leftover tissue or cosmetic reasons, you wait until the child is maybe 3 or 4 years old, after most of the shrinking has happened and it's much less vascular.
Okay, that covers IH really well. But then there are congenital hemangiomas,
Yeah.
CHs. How are they different?
Right, CHs are quite distinct. The big difference is timing. IHs develop after birth. CHs grow in the womb. They're fully formed when the baby is born.
So no postnatal growth spurt like IH.
Exactly. No postnatal proliferation. They're usually single lesions, often look reddish-purple, might have visible vessels on top, often a pale bit in the middle with a lighter halo around it.
Interesting look.
Yeah. And they tend to show up more on arms and legs and affect boys and girls pretty equally, unlike IH, which leans slightly female.
And you said there are 3 types: RISCH, PICH, NICH.
Yes. RISCH stands for Rapidly Involuting Congenital Hemangioma. These shrink really fast after birth, often gone by 12, 15 months.
Rapidly involuting makes sense.
Yeah. They can sometimes ulcerate or bleed as they shrink and very rarely cause temporary heart or clotting issues. Then there's PICH, partially involuting. They shrink, but not completely, leave some tissue behind.
Okay.
And NICH is non-involuting. They're there at birth, and they just stay there. They don't shrink on their own.
So their behavior right from birth is the main clue. How are they diagnosed? Is it just watching them?
Pretty much. The look at birth, that purplish thing with a halo maybe, plus high flow on ultrasound, and then seeing what happens over time. Rapid shrinking for ARECH, partial for PICH, or stability for NICH. That's key.
And the GLUT1 test.
Crucially, CHs are GLUT1 negative. That helps tell them apart from IHs if there's any doubt. And interestingly, there are specific gene mutations found in CHS GNAQ and GNA leavin.
Different biology again. So how do you manage these CH types?
Well, for ICH, mostly just observation since they go away on their own. Maybe surgery later if there's leftover skin or cosmetic issues. Rarely, if a huge RCH causes heart failure, you might need embolization or surgery.
And the ones that don't go away, NICH.
NICH lesions, since don't shrink and don't respond to meds like Propranolol, they usually need surgery if they're causing problems or look bad cosmetically. PICH management kind of depends on how much shrinks and what's left.
Got it. Okay, we've hit IH and CH. The source also quickly mentions a few others: spindle cell hemangioma, epithelioid hemangioma, and pyogenic granuloma. Just quick hits on these.
Sure, spindle cell hemangiomas, often superficial, can be painful, typically on hands, feet, can be single or multiple over years, sometimes linked to rare syndromes like Maffucci or Klippel-Trenaunay. Surgery usually cures them.
Okay. Epithelioid.
Epithelioid hemangioma, also usually benign, superficial, can sometimes pop up after trauma or pregnancy, might cause swelling, pain, can occur in bone too, where they look like holes, lytic lesions. Treatments varied: surgery, embolization, freezing, radiation, sometimes meds.
And pyogenic granuloma. I feel like I've heard of that one.
Yeah, they're pretty common. Look like a little red bump, often on a stalk, grows fast, bleeds really easily.
Right, the bleeders.
Exactly. More common in slightly older kids, often on the head neck, can be treated with scraping, cautery, excision, laser, but you got to get the whole base or they tend to grow back.
Okay, good to know. So a real mix of other benign types. Now, the source shifts gears a bit to intermediate tumors. Capiform hemangioendothelioma and tufted angioma. Sounds a bit more serious.
They are rarer, and they fall into this intermediate category because they can be locally aggressive, meaning they can invade nearby tissues.
But they don't spread elsewhere, like cancer.
Right. Importantly, they typically don't metastasize to distant sites. They often show up in newborns or babies as reddish-purple patches, often quite large, with fuzzy borders. And a big concern, especially with Kaposiform hemangioendothelioma, or KHE, is a complication called Kasabach-Merritt phenomenon. KMP.
Kasabach-Merritt. Okay, what is that?
It's a really serious condition. You get profound thrombocytopenia, dangerously low platelets, and a consumptive coagulopathy. Basically, the body's clotting system goes haywire within the tumor. It uses up all the platelets and clotting factors.
Wow, so risk of bleeding.
Major risk of bleeding. It happens in maybe 12–24% of kids with KHE, especially if the tumor is large or involves organs or muscles. Tufted angioma is often considered sort of a milder version on the same spectrum. There's an adult type of KHE too, but it usually doesn't cause KMP.
That sounds incredibly challenging to manage.
Yeah.
How are these diagnosed and treated?
Diagnosis involves the history, the exam, often imaging like MRI to see how infiltrative it is, and usually a biopsy. They often stain for lymphatic markers. Management has to be really tailored to the individual kid.
Depends on size, location, symptoms.
Exactly. And crucially, whether KMP is present, small, quiet ones might just be watched. But if it's causing problems, or especially if there's KMP, you need aggressive treatment.
Like what?
Often medical therapy, corticosteroids, sometimes vincristine, which is a chemo drug, or sirolimus, that's an mTOR inhibitor. These are often first line now, especially for KMP.
Does the treatment make them go away completely?
Not always. Complete regression isn't guaranteed, and unfortunately they can recur even after treatment, so it requires long-term follow-up.
Right. Okay, one last category mentioned is secondary tumors. What's the main point there?
Just that other childhood cancers, things not primarily vascular, like neuroblastoma, for example, can sometimes grow around or stick to major blood vessels. And in those cases, you obviously need a whole team oncology surgeons, including vascular surgeons, to plan how to deal with it safely, especially during surgery to remove the main tumor. Need to control the blood vessels.
Makes sense.
The source notes that complex vascular reconstruction, like replacing big arteries, is actually less common in kids than adults. And if they do need a graft for vessels going to organs, they often prefer using the kid's own hypogastric artery rather than a leg vein, because the artery might hold up better as the child grows. There are some figures in Rutherford showing examples, like tumors wrapped around the aorta or stuck to iliac arteries. Really highlights the need for that vascular expertise in complex pediatric oncology surgery.
Okay, so really wrapping this all up, the absolute key message seems to be classification matters a lot.
Precisely. That's the #1 takeaway. Pediatric vascular lesions are this incredibly diverse group. Getting the category right, is it a tumor or a malformation? If it's a tumor, is it benign like an IH or intermediate like KHE? That initial classification is absolutely essential. It dictates everything that follows in terms of management.
And for the more complex ones, having that multidisciplinary team is non-negotiable, really.
Couldn't agree more. Expert care, usually at a specialized vascular anomaly center where you have dermatology, radiology, surgery, hematology, genetics, all collaborating. That's critical for accurate diagnosis and getting the best, most tailored treatment plan for these kids.
It really makes you think, though, with all the progress in understanding the genetics and the molecular pathways behind these tumors, what's next?
Right.
Could we see more personalized treatments in the future? Maybe drugs that specifically target those GNAQ mutations in CH or the pathways driving KHE?
That's definitely the hope and where a lot of research is heading. Developing therapies that are more targeted and have fewer side effects, it's a really active field.
Absolutely. Well, for anyone listening who wants to learn more, definitely check out resources from dedicated vascular anomaly centers or dive into the medical literature. There's a lot happening.
Indeed. It's a field with huge potential to keep improving outcomes for children affected by these conditions.